The oxazaphosphorines, including cyclophosphamide, ifosfamide, trufosfamide, represent an important group of therapeutic agents due to their substantial anti-tumor immunomodulating activity. Cyclophosphamide and ifosfamide, as these two oxazaphosphorines, are the most widely used alkylating agents. Both cyclophosphamide and ifosfamide are prodrugs that require activation by hepatic cytochrome P450, catalyzed for hydroxylation, yielding cytotoxic nitrogen mustard capable of reacting with DNA molecules to form cross-links and lead to cell apoptosis and necrosis. The majority of anti-neoplastic effects of cyclophosphamide are due to phosphamide mustard formed from metabolism of the drug by liver enzymes like cytochrome B450. Leukopenia is the dose-limiting toxicity of cyclophosphamide, and neurotoxicity is the dose-limiting toxicity of ifosfamide when preventive measures are taken to reduce urotoxicity. Acrolein is excreted in the urine and irritates the bladder wall, causing various adverse effects from urinary frequency, urgency, pain, and nocturia to hemorrhagic cystitis. Resistance to oxazaphosphorines is poorly understood, although increased aldehyde dehydrogenase activity may be a significant factor. In this slide, we're gonna simplify the mechanism of action as much as we can for cyclophosphamide and ifosfamide. Let's get started. The cyclophosphamide is converted by hepatic cytochrome P450 to its metabolite called phosphoramide mustard plus acrolein. The active metabolite of phosphoramide mustard is reacting with DNA molecules to form cross-links. DNA at guanine N7 position leads to cell apoptosis, which eventually leads to anti-neoplastic effects. When it comes to the acrolein, which is excreted in the urine and causes hemorrhagic cystitis. The ifosfamide is converted by hepatic cytochrome P450 to its active metabolite, which is called ifosfamide mustard plus acrolein, which is excreted in the urine and causes hemorrhagic cystitis. What chemoprotective or uroprotective mesna effect is? Uromethixane or mesna, or even can be called sodium 2-mercaptoethane sulfonate. It is completely excreted in 4 hours if given intravenous and in 8 hours if given orally. The mesna is inactivated to dimesna, mesna disulfide in the bloodstream. Afterward, reactivated mesna concentrates in the bladder. Mesna easily detoxifies the cyclophosphamide and ifosfamide toxic metabolite acrolein. The acrolein stimulates the release of inflammatory mediators, interleukin-1, beta tumor necrosis alpha, and endogenous nitric oxide, including vascular dilatation, mucosal edema, capillary fragility, resulting in hemorrhagic cystitis. To summarize, in a nutshell, mesna plus acrolein leads to make mesna acts as a sulfahydryl donor that forms a conjugate bond with acrolein. Mesna finally inactivate acrolein to a non-toxic compounds, preventing hemorrhagic cystitis. According to a comparative study between cyclophosphamide and ifosfamide, which published in May 1991 in a peer-reviewed oncology journal, Williston Park, the ifosfamide is a newly available analog of cyclophosphamide in oxazaphosphorine drug class. Cyclophosphamide has been marketed for 32 years, which means now around 60 years, and it remains a highly effective agent for a wide cross-section of malignancies. Ifosfamide has a similar spectrum of anti-tumor activity, but has different pharmacokinetics that could provide advantages in efficacy. Although ifosfamide has been substituted for cyclophosphamide in many therapeutic regimens, it has not been proven superior to cyclophosphamide in any cancer. The ifosfamide current use in non-investigational therapy is for metastatic testicular carcinoma and sarcomas. Ifosfamide has a disadvantageous toxicity spectrum compared to cyclophosphamide and a greater financial cost. For most malignancies responsive to an oxazaphosphorine, the analog of choice will remain cyclophosphamide. We finally should also know some crucial information pertaining to cyclophosphamide and ifosfamide. When it comes to the cyclophosphamide, while oral and intravenous treatments delivery methods of cyclophosphamide have been shown to be equally effective, The intravenous route is thought to have less toxicity than oral administration. Cyclophosphamide is one of the most successful chemotherapeutics. Cyclophosphamide has proved to be safe and has revealed its many capabilities and versatilities of clinical uses. The cyclophosphamide is cell cycle non-specific alkylating agent that prevents cell division by cross-linking DNA strands and decreasing DNA synthesis. Cyclophosphamide has a potent immunosuppressive activity, and it is a prodrug that must be metabolized to active metabolites in the liver. When it comes to the ifosfamide, we should remember that the primary route of administration for ifosfamide is intravenous. The oral form had a bioavailability close to 100% but resulted in severe neurotoxicity, and since then, the administration route has switched to intravenous administration. The ifosfamide is emetogenic, hence antiemetic are routinely prescribed to prevent chemotherapy-induced nausea and vomiting. Precipitation of ifosfamide-induced encephalopathy by aprepitant has been reported in the literature. Ifosfamide causes cross-linking of strands of DNA by binding the nucleic acids and the other intracellular structures, resulting in cell death, inhibits protein synthesis and DNA synthesis.